Okay, thanks guys. That was a terrifically informative. It's a nice segue into our next presentation, which is a recorded video from one of our anesthesiology members, Dr. Emily Garmon. She's going to enlighten us on regional analgesia options, which is the best one for ribs. She is a anesthesiologist at Baylor Scott & White Medical Center in Temple, Texas, and she's been there for 15 years. She's an associate professor of anesthesiology and medical director of the Hospital Pain Management Service. Dr. Garmon.
I'm Dr. Emily Garmon, and I'm the medical director of the acute pain service at Scott & White Hospital in Temple, Texas. And my topic today is regional analgesia options, which is best for ribs. So as you can tell from the title, the focus of today's talk is not whether regional analgesia should be used, but rather which techniques should be used in any given clinical situation. But to be fair, I think it's important that you know that there are meta-analyses data that demonstrate no benefit to regional analgesia and rib fracture management. But with that being said, I believe that the weight of the published evidence as well as my own clinical experience favors the use of regional analgesia, so I'm starting with the premise that regional analgesia is beneficial. So my objectives for today are to discuss reasons for incorporating regional analgesia into rib fracture management, to review thoracic sensory innervation, to examine 4 regional analgesia procedural techniques, and then to recommend approaches for deciding which procedural technique to utilize. So why? Why should you utilize regional analgesia in rib fracture management of hospitalized patients? Well, rib fractures in general have high morbidity and mortality, and especially with increasing number of rib fractures, with older age, with pre-existing comorbidities, and the level of associated pain or impaired function. So if we can improve pain, then hopefully we can improve function and outcomes. So the data from multiple retrospective studies have demonstrated favorable efficacy and safety profiles compared to non-procedural alternatives. Regional analgesia has been shown to improve pain, improve ventilatory mechanics, improve ambulation, reduce critical care admissions, ventilator days, and critical care length of stay, and also reduce hospital length of stay. And then in addition, it reduces opioid consumption, reduces opioid-related side effects like nausea, vomiting, pruritus, and oversedation. And it comes at a very low risk for procedural complications, but those can include neurologic injury, infection, bleeding, or local anesthetic toxicity. So where can you perform regional analgesia for optimal thoracic coverage? Well, starting centrally and moving peripherally, the thoracic spinal nerves exit the spinal cord and travel laterally into the paravertebral space. Then it splits into the posterior ramus that innervates the posterior thorax and the ventral ramus that innervates the anterior and lateral thorax. The ventral ramus makes up the intercostal nerve, and then it travels around to the lateral and anterior thorax, giving off the anterior and posterior branches of the lateral cutaneous branch. So sensory transmission occurs from peripheral to central. So signal transmission can be blocked at multiple locations through this pathway. Starting centrally, it can be blocked at the epidural space. Moving peripherally, it can be blocked at the paravertebral space. Then it can be blocked deep to the erector spinae muscle that is a little bit more lateral and superficial to the paravertebral space. It can be blocked in the intercostal space, but we're not going to talk about this one today because that limits you to only one dermatome of coverage. And then it can be blocked in the serratus anterior plane. And all locations are amenable to catheter placement and can be performed as high as the T4 or 5 interspace levels or the 5th rib. So for placement of an epidural catheter, the technique includes injection of local anesthetic into the thoracic epidural space. It blocks sensory transmission as it enters the spinal cord so that it doesn't travel centrally. In terms of benefits, it's long been considered the gold standard in analgesic management of traumatic rib fractures due to the profound analgesia that you achieve with it. It's quick and easy to perform for experienced providers. It doesn't require ultrasound guidance, and it provides bilateral coverage of up to 6 or more dermatome levels with only a single catheter being placed. Drawbacks, it's contraindicated in the presence of coagulopathy, meaning platelets, PTT or PT and INR are out of your institutional normal range, or they're on systemic anticoagulation, and this is due to the risk of the catastrophic complication of epidural hematoma. It's contraindicated in multi-system trauma, brain injury, increased ICP, or spine injury that's close to the level that you would be placing the epidural, and it requires sitting or lateral decubitus position during placement. With regard to hypotension, it does cause a sympathectomy, and that can cause worsened hypotension if it's already pre-existing, or can cause hypotension to develop. Although urinary retention and lower extremity motor blockade are also sometimes demonstrated as contraindications to an epidural or adverse effects of an epidural, this should not occur if you're above the level of T8. With regard to paravertebral blocker catheter, that technique involves injection of local anesthetic superficial to the pleura in the unilateral paravertebral space, which is contiguous with the epidural space. It blocks both the dorsal and ventral rami of the spinal nerves. In terms of benefits, it's non-inferior analgesia as compared to thoracic epidural, which has been demonstrated in multiple studies and meta-analyses. The hypotension risk is minimized compared to thoracic epidural, although local anesthetic can spread centrally in 10% or more of these procedures, so it is still a risk. It's quick and easy for experienced providers, especially with the use of ultrasound guidance, and it provides unilateral coverage of up to 6 or more dermatome levels unless you place bilateral catheters. In terms of drawbacks, it's contraindicated in the presence of coagulopathy, again because of central spread due to the path of least resistance, which can cause epidural hematoma. It's contraindicated in thoracic spine trauma near the level of the catheter due to loss or distortion of landmarks. It requires sitting or lateral decubitus position during placement, and the risk of intrapleural injection or pneumothorax is due to the proximity to the pleura. Ultrasound is preferable in order to reduce this risk. So with ultrasound, you would use an in-plane parasagittal approach. You identify the transverse process, the costotransverse ligament, and the pleura, and then you inject your local anesthetic superficial to the pleura and pass your catheter if you want one. For the erector spinae blocker catheter, that technique involves injection of local anesthetic deep to the erector spinae muscle and superficial to the transverse process. This location is more superficial and lateral to the paravertebral block location. It blocks both the dorsal and the ventral rami of the unilateral spinal nerves as they travel through the adjoining tissue plane. Benefits with that, it's possibly non-inferior analgesia as compared to a thoracic epidural in some retrospective studies as quantified by morphine equivalent usage, but other studies demonstrate better pain scores with epidurals. It's remote from the epidural space, so hypotension and bleeding risk are minimized in some studies, in some cadaver dye studies that demonstrate spread, and it's completely eliminated in other ones. It's quick and easy for experienced providers with ultrasound guidance, and it provides unilateral coverage of up to 10 or more dermatome levels because it spreads very widely through this tissue plane. With regard to drawbacks, it's contraindicated in thoracic spine trauma if it involves a transverse process, again because of distortion or loss of the bony landmark, and it requires sitting or lateral decubitus position for placement. So with ultrasound, you would use an in-plane parasagittal approach. Again, you would identify the trapezius, the rhomboid if you're above the level of about T6 or so, the erector spinae, the transverse process in the adjoining rib, and then you would pass the needle tip to the erector spinae, through the erector spinae, and inject just superficial to the transverse process and pass a catheter if you wanted that. As for the serratus plane block or catheter, that technique involves injection of local anesthetic, either superficial or deep to the serratus anterior muscle at the 5th rib level. It blocks the ventral rami and the anterior and posterior branches of the lateral cutaneous branch of the unilateral spinal nerves. Benefits: it's possibly non-inferior analgesia as compared to a thoracic epidural for anterior and lateral rib fractures, again, with the same caveat concerning opioid consumption versus pain scores. It's placed in the anterolateral thorax, so there's no change in position that's required for placement of this blocker catheter. It's quick and easy for experienced providers with ultrasound guidance, and it provides unilateral coverage of up to 6 dermatome levels, especially, again, with ultrasound guidance and movement of the needle, passage of the needle over multiple rib levels. Drawbacks: it does have inadequate coverage for posterior rib fractures. So with ultrasound, again, you would use an in-plane approach. You would identify the inferior edge of the teres major muscle, the latissimus dorsi, and the serratus anterior muscle overlying the 5th rib. Then you would pass the needle and inject local anesthetic, either superficial or deep, to the serratus anterior muscle. In this image, it's shown deep to the serratus anterior muscle. And then in this image, you can see following the needle down multiple rib levels, and you can ensure spread up to 6 or more dermatome levels. The superficial location is usually preferable for placement of a catheter because catheters reduce the intercostal uptake of continuous local anesthetic infusion. And the deep location is usually preferable for single shot injections because it's very easy to identify the rib and the landmarks, the appropriate tissue planes in order to inject the local anesthetic. And then don't forget non-procedural analgesia in low-risk patients that you don't provide procedures for. Those that are younger, they have minimal comorbidities, they have less than 3 rib fractures or well-tolerated pain, as well as those who you do provide procedures for. So acetaminophen and an NSAID or a COX-2 inhibitor if there's no contraindications, using gabapentinoids for neuropathic pain, targeted use of methocarbamol for intercostal muscle spasm, and then opioids for breakthrough pain, oral first and then proceed to intravenous. And then finally, if you have a high-risk patient but procedural analgesia is contraindicated, you can use continuous lidocaine infusion, continuous ketamine infusion, or magnesium. So how do you decide which regional analgesia procedure to perform? First, you look at patient characteristics. If you have a patient that's over the age of 65, they have multiple comorbidities or COPD, sleep apnea, morbid obesity, they have greater than 4 rib fractures, or they have intolerable pain or poor functional status, these are all good candidates for procedural interventions. And then based on fracture location, epidurals cover bilateral fractures in the anterior, lateral, and posterior thorax. The others require bilateral catheter placement if you have bilateral fractures, and the serratus plane block doesn't cover the posterior thorax. And then as for other coexisting conditions, epidural is ruled out in coagulopathy, hypotension, brain or spine trauma, and inability to position. And then paravertebrals have to be used with caution with coagulopathy and hypotension and should probably be considered equivalent to epidurals in terms of risk. And really, caution should be used for all patients with coagulopathy because bleeding risk is still present, even though the more The less severe the bleeding sequelae becomes. The The erector spinae has less risk than an epidural or a paravertebral, but possibly less effective analgesia. And the serratus plane probably has the least risk of all the techniques. It requires no repositioning to place, but possibly has the least effective analgesia because it does not cover the posterior thorax. So these are my references in case you would like further reading on the topic, and thank you for having me today.